Good afternoon, everyone. Welcome to this webinar on the three-vessel tracheal view, a review of normal and abnormal findings, presented by Ms. Tracy Anton. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. At the completion of this webinar, participants should be able to review normal 2D ultrasound anatomy and the appearance of common abnormalities seen in the three-vessel tracheal view, as well as describe the appearance of normal color Doppler findings. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Tracy Anton and Kathy Minton have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Ms. Tracy Anton.
Okay. Hi, thank you for having me today, and thank you to the AIUM for inviting me to give this webinar on the three-vessel trachea view. I put together some cases to review the normal and abnormal findings. This is a view that has really become very useful in our lab in order to refine and detect more congenital heart disease, and more importantly, critical congenital heart disease, which is what we're all here to do. So let me go ahead and start by just describing the three-vessel view. So it's an axial view of the upper mediastinum, simultaneously demonstrating the course and the connection of the ductal and aortic arches, arch-sidedness, aortic and ductal arch-sidedness, as well as the size, proportions of the vessels, the location of the superior vena cava, or vena cavas if bilateral, and also the presence of the thymus gland. With the addition of color Doppler flow, it also shows you the direction of flow, which is critical when you're trying to refine a diagnosis. So the advantages of the three-vessel view are, I think its number one advantage is that it's easy to obtain and learn to interpret throughout gestation. So if you can get a four-chamber view, you can get a three-vessel view. It also allows simultaneous visualization of both the ductal and aortic arches, which is going to help us, again, detect ductal-dependent lesions. And this is in contrast to the traditional sagittal views of the aortic and ductal arch, which you have to pan back and forth in between. Here you can see both at the same time for evaluation, which I think is critical. It's abnormal in most congenital heart disease that involves the outflow tracts. And it's particularly useful when you're scanning the technically difficult patients. These include the early gestational age, so our first trimester nuchal translucency age, as well as in the advanced gestational age where you're having more issues getting images from shadowing from the fetal ribs and spine, and also in patients with elevated BMI. This has helped me a lot in my screening echocardiograms, and I'll show you how I do that. So let's first just start by reviewing where we're at with the guidelines right now. So the latest guidelines from AIUM as well as ISWOG all require that we do the 4-chamber LVOT and RVOT. Currently, the basic obstetrical guidelines do not require us to obtain the 3-vessel and 3-vessel trachea view. The ISWOG guidelines do talk about it and say it's desirable. However, it's only when technically feasible and not necessarily required. So this is the status of where we're at, but hopefully in the near future this will be reevaluated, as this, again, has been a view that's extremely useful, particularly when screening for congenital heart disease. Now, when we look at our fetal echo guidelines, the AIUM practice guidelines do require that we obtain the 3-vessel and the 3-vessel trachea view with color as well as with 2D. So next I'm just going to move into the technique, and this is probably the easiest part for me to describe. Again, if you can get a 4-chamber view, you can get a 3-vessel view. So you obtain a transverse view of the chest, the level of the 4-chamber view, and you simply angle up towards the baby's head, and we're going to run right into our 3-vessel and 3-vessel trachea view. And I think this very simple sweep, so in terms of thinking of doing your exams not just with still images or with cine clips, but also incorporating sweeps is going to be very useful for you in improving your detection of heart disease. Here we show just sweeping up from the 4-chamber view, again, up into the 3-vessel and 3-vessel trachea view. And with this 1 3-second sweep alone, we've already ruled out the majority of significant congenital heart disease. And if we added color Doppler, we would even have that much higher detection rate. So now to just kind of back up and look at the anatomical components that we see in the 3-vessel view. So we have our main pulmonary artery, which continues to the ductus. The middle vessel is the ascending aorta. And the most rightward and posterior vessel is your superior vena cava. So these vessels should be orientated from left to right, from anterior to posterior. With this oblique orientation, you can draw this line down. And just to, I'm going to back up on that slide real quick, because one other thing I want to mention is also with the sizes of the vessels, not only from left to right, anterior to posterior, but also should be from largest to smallest, with the pulmonary artery being equal to or larger than the aorta, and the aorta being larger than the SVC. So this is a view that I also use routinely in order to be able to confirm that the branched pulmonary arteries are confluent. So again, this isn't required in your basic anatomical survey, but certainly is something that we need to do for fetal echo, and I use the 3-vessel view all the time in order to do this. So normally our right pulmonary artery we see pretty easily as it runs, that courses posterior to the aorta. Our left pulmonary artery can be hard to see sometimes because the ductus just overlaps it as we move up just a little bit higher in the chest. But with a little bit of work, we can tease out this left pulmonary artery as it tapers off into the left lung, and therefore confirm that we have confluent branched pulmonary arteries. So with just moving a few millimeters higher in the chest, we'll move into the 3-vessel trachea view. So again, from the 3-vessel view, just moving a little bit higher, and with a slightly leftward oblique orientation, we'll run into the 3-vessel trachea view. So when we look at these components, so again, we see the pulmonary artery running into the ductus arteriosus. We see the aorta as it goes into the aortic arch and merges with the descending aorta. And this should make a V configuration. And what's most important about this is we also note the trachea in this view. And this trachea we'll recognize as a hypoechoic structure that has a bright echogenic rim around it that's bright because of the cartilage rings that surround the trachea. It can help you recognize the structure. So the orientation of both the aorta and the ductal arches being to the left of the trachea really defines them both as a left ductal arch and a left aortic arch. And this is really the view that you're going to easily be able to pick up right aortic arch or other type of arch anomalies, which I'll show you later. With high-resolution ultrasound in this view, we also can pick out the thymus gland, which is slightly more hypoechoic when compared to the echotexture of the lungs. And it sits right in front of these great vessels here. And this becomes significant, particularly in the case of congenital heart disease, where we have conotruncal anomalies. We're going to want to confirm the presence of this gland, because when we see that it's absent or hypoplastic, that will certainly make us more worried about 22q deletion syndrome. So this identification and getting used to seeing this thymus gland is helpful. There has been techniques that have been published in order to measure the thymus gland. But seeing the great vessels orientated in the middle of the chest really suggests that there is a thymus gland present, because it is a space-occupying tissue. So what to look for? So 3 vessel views. So 3 implies that there should be 3 vessels. So your number of vessels. Proportions. The pulmonary artery, again, should be equal to or slightly greater in size than the aorta, and the aorta should be larger than the SVC. The course of these vessels should be in a V configuration, again, V for victory, and the relationship of the trachea to the trachea should be leftward. The thymus gland should be present, and we also should see normal color Doppler flow, which I'm going to show you that in the following slides. So what to look for with color Doppler? So color Doppler is very important, and what we're looking for is that we're seeing antegrade, meaning the flow is going towards the descending aorta, and it's laminar, no turbulence, and it's flowing towards the spine, again towards that descending aorta, and that both of these arches meet to the left of the trachea. So for this particular view, I do set my scale around 50 to 60 centimeters per second. Should get you in about the right place. You can also use the directional independent Doppler as well, but you want to make sure and adjust your PRF, turn your scale up to get rid of that turbulence, and also adjust your gain as well to help you really see the course of the vessels well. You can see also that I have a nice small color box in order to maintain a high frame rate. So I did want to bring up a couple other different scenarios. So of course we want to see that the flow is going towards the descending aorta. So in this case up in the left, we see that both of the flow is blue away from the transducer. If your spine is orientated upward, again, it could be red towards the spine. But if the spine is in approximately the 4 or 8 o'clock position, you may notice that the vessels have different colors. So this is where you need to keep in mind the physics of ultrasound. So if we look carefully at this view, we see that the orientation of the aorta is still going up towards the descending aorta, and the orientation of the pulmonary artery and the ductus is still flowing down. So these are all cases of normal color Doppler flow. And we use the 3-vessel view in our first trimesters in our lab as well, and the addition of color Doppler when we're evaluating these in the early gestational age is essential. We do try and see it in 2D as well, but you can see with the addition of color Doppler that we're able to see much more detail. You can actually start to see that V configuration, and this can help us rule out early significant congenital heart disease. As I mentioned before, I use this view routinely also to help clear out our technically difficult patients with high BMIs. So I do a lot of screening echocardiograms on the diabetic patients that everyone had a hard time seeing the screening views on. This is where the 3-vessel view becomes really important. So we can see we have all this extra tissue to try and penetrate through, and even using all of my best optimization techniques, I still have some difficulty even in 2D getting my 3-vessel view, although we can start to see here the pulmonary artery, aorta, and SVC. But with the addition of color Doppler, layered on top of that, now I'm feeling much more comfortable that the size of the vessels look appropriate and that the blood flow is going in the correct direction towards the spine. And if I can get this along with a good 4-chamber crossing great vessels, then again, we've been able to rule out a significant amount of serious congenital heart disease in these very difficult to scan patients. So this patient, much easier to scan when, again, using high-resolution ultrasound and lower scale settings. You can recognize the azygos vein, which is a normal vessel that we see routinely. It flows, the blood flow is directed into the superior vena cava. So in this particular patient, I'm using the directional independent Doppler. So much lower scale settings as this is a low flow structure. But this vessel, again, it's normal. The normal size is about 1/3 of the size of the aorta, and that is throughout gestation. Occasionally we'll see it be dilated in cases of interrupted IVC with azygos continuation. So certainly you may notice it more prominent in cases in abnormalities, but this is a normal structure that you can recognize in this view as well. So next I wanted to move into more of an extended interrogation, a little bit higher than the 3-vessel trachea view. So if we continue to move higher up in the chest, we'll see the left brachycephalic vein. And the left brachycephalic vein is formed from the jugular vein and the left subclavian vein, and that vessel tracks across the chest, obliquely to drain into the superior vena cava. So again, as you continue to come up, slight leftward angulation, and this is with color Doppler as well. We can see that blood flow again flowing from left to right. Just behind it, we're seeing the head and neck vessels of the aorta, as well as the trachea in this view and the thymus gland in front. So it's very easy to see this, and as we come apart, you just want to make sure that you distinguish it from the aortic arch, because again, remember, the aorta is running posteriorly towards the spine to the left, whereas the left brachycephalic vein is running from left to right across the chest. So you want to make sure and distinguish the two, and both will have obviously different Doppler patterns as well as arterial versus venous. So what is the significance of seeing this? So the significance is with its size. It will be dilated in cases of supracardiac TAPVR or any vein of Galen aneurysm or any extra flow related anomalies. Also in its presence or absence, it's almost always absent in the presence of bilateral SVCs as well. And if you look at this vessel routinely, you'll notice that there are variants in its course as well, as it can be intrathymic, retroaortic, or retrotracheal in its course as well, and these variants are of uncertain clinical significance. So typical abnormalities that you'll see in the 3-vessel trachea view is, again, it should be 3 vessels, so abnormal vessel number, abnormal vessel size, the course and alignment, and the color flow direction. You could see abnormal direction or flow turbulence. And often with heart disease, you'll see more than one sign present at the same time. So first, let's talk about abnormal vessel number. So if you have too many vessels, 4 instead of 3. So this can be seen with an extra vessel to the left of the pulmonary artery. And most commonly when you see this, this is going to be a persistent left superior vena cava. As you know, embryologically, we start out with 2 SVCs, and the left-sided one goes away and the right-sided one normally persists. But this can also be a vertical vein in supracardiac TAPVR. So here's an example showing us 4 vessels. So we have the pulmonary artery, aorta, SVC, and here is our 4th vessel. And with persistent left SVC, that blood flow drains into the coronary sinus. So your first clue to this finding will often be in the 4-chamber view, where you have a dilated coronary sinus. not to be mistaken for an atrial septal defect, as the coronary sinus is behind the heart and sometimes can obscure the crux of the heart and make you think that this could be an atrial septal defect when indeed it's just a dilated coronary sinus. And we see as we scan back and forth how we actually come into the true plane of the four-chamber view, both AV valves moving here. The coronary sinus appears to be a circular structure in the true plane of the four-chamber view, and you can see it as it merges in behind the heart. And as we come up higher, we can see this persistent left SVC. So we talked about one way to distinguish a persistent left SVC from supracardiac TAPVR would be that with persistent left SVC, the blood flow drains to the coronary sinus, so you'll have a dilated coronary sinus. But I wanted to show you another way that you can distinguish that, and that's by moving up higher into the chest. Again, I showed you the left brachiocephalic vein, or the bridging vein as it comes across. But when you have a persistent left SVC, you don't need a bridging vein because that blood flow from the left side is draining down into the coronary sinus. So as you come up higher, you'll notice there's an absence of the left brachiocephalic vein when you have persistent left SVC. So this is in contrast to supracardiac TPVR, which most commonly drains into the left brachiocephalic vein. Again, the extra volume flow makes it become dilated, and this, I think, becomes a very easy clue that we can look for to rule out a significant heart disease and TAPVR that's often very difficult for us to diagnose normally. So I think this could be an important clue. And also with supracardiac TPVR, you won't have any extra volume flow going to the coronary sinus. You'll have a normal coronary sinus in these patients. So here's another example of abnormal vessel number. So this I said 4 in quotations because there truly isn't 4 vessels, but sometimes can be construed as 4 as you come up higher in the chest. So here we see our pulmonary artery, aorta, SVC, and we see this twisting vessel. So this is something that we see not uncommonly in the 3rd trimester. And this is ductal tortuosity, kinking, or bending. And this is almost always a benign finding that we see because we know that after birth the ductus closes, and so it doesn't need to be open anymore, and it doesn't cause any problems for the baby. So it can be kinked, it just needs to be open. And this is just showing the configuration, and it can look differently. I'm going to show you another case in a second here. This is with color flow. You may see some turbulence as it comes through and makes these little bends here, but again, this is almost always benign. As long as your 4-chamber view looks normal and you don't see any evidence of any cardiac dysfunction or tricuspid regurgitation to make you think that the ductus is actually restricted, then this is just fine and normal to see. This is another example of ductal tortuosity or kinking. So again, you can see how if you're looking at this quickly, you may think that there's an extra vessel here, when if you follow this out, this is actually just a kinked ductus arteriosus in a normal heart. So next, let's talk about too few vessels. So if we have 2 instead of 3. So when you see 2 vessels in the 3-vessel view, the first thing you want to ask yourself is this single vessel normal in size? If the single vessel is normal in size in the presence of the superior vena cava here, this is almost always an example of transposition of the great vessels. So if we work at it here, we see that we can actually see all 3 vessels. So the aorta is anterior to the pulmonary artery, which we can see branching here in the SVC. So as we angle up just slightly higher, we see that this aorta actually overlaps the pulmonary artery and makes it appear as if there's only one vessel. So this is an example of detransposition of the great arteries. And when you see this, this is actually a very good clue and another diagnosis that can be very difficult to make. But 2 vessels in the 3-vessel view can be one of your first easy clues to this critical diagnosis to make. I also wanted to draw your attention to the shape of this vessel. So since the aorta is coming off the more anterior right ventricle, it has to make a little bit more of a bend as it comes back before it merges with the descending aorta. So you'll notice that it has more of a convex shape than we're used to seeing. So this is another clue that you can use in this view to see a convex aorta. This is another case. Again, we can see that it kind of makes a more exaggerated bend here and is more convex in shape than we typically see in this plane. And this is another example of transposition of the great vessel. So here we see the aorta slightly more leftward to the pulmonary artery and the SVC here. And here we can confirm that it's the pulmonary artery by seeing the branching. So again, this is a different configuration of transposition where we don't have the overlap. It's certainly an abnormal configuration in this baby with L transposition or corrected transposition of the great vessels. So now let's talk about 2 vessels instead of 3, but now you have a single dilated great vessel. So when we see this, so this is a 35 or a 36-week fetus. We have a very dilated great vessel. Here's our SVC. This is the descending aorta here and the trachea over here. So this is another case where the color Doppler, the addition of the color Doppler is going to show us some turbulent flow. So we have some swirling here. This is highly suspicious of an abnormal valve. So this is 2 vessels with a dilated single abnormal valve as diagnostic for common arterial trunk. And here again, we can actually see the branch pulmonary arteries coming off in this image as well. So again, we have a large single dilated vessel with a normal size SVC, and this is what it looks like. This is a parasagittal plane showing a highly stenotic as well as regurgitant valve in this plane as well. And you notice in the schematic that I showed you that I didn't add the branch pulmonary arteries, and this is because for screening purposes, once we see a dilated great vessel with a very abnormal stenotic regurgitant valve, at that point we're already very highly suspicious for common arterial trunk. And when we're looking for the branch pulmonary arteries, which are typically very difficult to see during fetal life, we're really just refining the diagnosis when we already really know that it is common arterial trunk. And again, also just notice how dilated, this is what we saw in the 3-vessel view, how dilated the artery is as you go higher. So next I want to talk about abnormal vessel course or alignment. So here we have our normal, again with the aorta and the pulmonary artery with the ductus merging to the left of the trachea. But you can have a right-sided ductus, a left-sided ductus with a right-sided aortic arch that makes a U-shaped configuration around the trachea or a loose ring. Both arches can merge to the right of the trachea. This is mirror imaging, right aortic arch as well as right ductus. And you can also have a left-sided ductus with a double arch, so a left-sided arch and a right-sided arch, and this is a tight vascular ring. So the most common type of arch abnormality that we see in our lab is right aortic arch, or making the U-shaped configuration. So here we can see the pulmonary artery coming back to the ductus, as well as the aorta here and our trachea in the middle. And I think this is another example where color Doppler really helps us a lot. So this is 2D, and we can see this is suspicious. We're not seeing the normal V-shaped configuration. But when we turn on the color Doppler, again, it becomes much more clear that this is right-sided aortic arch, left-sided ductus. This is another example, just a little bit of a different orientation, again, making that U shape. And this one, a little bit more complicated. This is an example of a double aortic arch. So here we have our pulmonary artery and ductus coming to the left. Here's our aorta, and as we see one arch coming over to the right, but then a second branch coming over towards the left, and again encircling that trachea in a tight vascular ring. Typically in these cases, the right-sided arch is dominant, so you're going to first suspect this with a right-sided aortic arch, but then you really need to go hunting to see if there's a double arch with a more hypoplastic left-sided aortic arch as well. So again, the color Doppler is really going to be your key for that. So next I'm going to talk about a dilated pulmonary artery. So when we see a dilated pulmonary artery, if it's very dilated, with dilated branch pulmonary arteries, this would be tetralogy of Fallot absent pulmonary valve. If it's mildly dilated with a normal sized aorta, you want to make sure and check the pulmonary valve, as that could be pulmonic stenosis with post-stenotic dilation, which is what we're seeing here. So this is more of a subtle case, but it does look a little bit more like it's bulging more than we're used to seeing. And again, addition of your color Doppler with good optimization of your settings, turning your scale up high, we can see there's a little bit of regurgitation and some swirling flow, and this valve is stenotic. So this is diagnostic of pulmonic stenosis. Here is our traditional views in an RVOT. We can see that the valve is thickened and not moving well, and again with the color flow we see some regurgitation as well as some alicing and swirling across that abnormal valve. And as I mentioned before, if the pulmonary artery and the branch pulmonary arteries are very dilated, then you want to think about absent pulmonary valve syndrome. When you turn on the color flow, these valves are very abnormal, so again, stenotic and regurgitant at the same time, or that to and fro flow pattern that we see there. So now moving into a small aorta. So when we see a small aorta, so again, if we look here, the aorta is a little bit smaller, possibly equal to in size of the SVC, but it always should be larger than the SVC. At the same time, the pulmonary artery looks like it's carrying a little bit more flow than we're used to seeing. So this is a dilated pulmonary artery with a small aorta. This is the first thing you want to think of with these cases is coarctation of the aorta. So there's other clues we can look for. Again, this is a very difficult diagnosis, so you may see right heart disproportion at the level of the four-chamber view, although this is pretty subtle. If you're lucky, you may get a good view in the aortic arch view as well, although I found that this can be difficult to tease out because, again, your ductus sits very close to this. It sits very close relatively to the aortic arch, so you can easily get ductal overlap in these sagittal views, which makes them very tricky. So if we see a small aorta, a dilated pulmonary artery, you also want to make sure that you can follow this aorta all the way back to the descending aorta. It needs to make this V configuration, so don't just stop here. If you cannot extend the aorta and you're getting normal forward flow like it should be going towards the descending aorta, then you should be very suspicious for aortic arch interruption, which is what we have in this case here. And this is showing in our sagittal view. We're seeing images of the ascending aorta into the transverse, and then a little bit of a break as it extends into the descending aorta. Now, here is in the three-vessel view, if we're seeing a small aorta and we're seeing reverse flow in the ascending aorta. It's going back towards the coronary arteries in the ascending aorta. This is significant for critical abnormalities of the outflow tract, such as in hypoplastic left heart or critical aortic stenosis, which in this case, this was critical aortic stenosis. So if you have a small pulmonary artery with a somewhat dilated ascending aorta, the first thing that you want to think about is tetralogy of Fallot. So the pulmonary artery should never be smaller than the aorta, and there really aren't a lot of rules with cardiac, but that is one of them. That is never normal. So be highly suspicious of an abnormal aortic valve with poststenotic dilatation or an abnormal pulmonic valve. So the color flow now confirms that the flow across the pulmonary valve is abnormal. So again, we're seeing this swirling flow in the main pulmonary artery, as well as some stenosis here. So this is tetralogy of Fallot with pulmonic stenosis in the three-vessel view. And these are the traditional views we see here with the overriding aorta, again with the abnormal pulmonic valve. Now, if you have a reverse-orientated ductus, so you have reverse flow perfusing the branch pulmonary arteries and the main pulmonary artery, this is again significant for critical outflow tract obstruction, so pulmonary atresia. In this case, this was pulmonary atresia intact septum. So now I'm going to go through a couple unknown cases. So here's a patient. This patient was actually referred for a fetal echo because the pulmonary artery was smaller than the aorta. They didn't have any other suspicions, but they were concerned that the pulmonary artery should never be smaller than the aorta, so they sent it for a formal fetal echo. So this looks very similar to the case we just saw, tetralogy of Fallot, which would be the first thing that you would think of. But this is where really the other views obviously come into play, but also your color Doppler is going to help you here. When we turn on the color Doppler, we see that we have nice forward flow through the pulmonary artery, but here we have swirling flow in the ascending aorta. So this is concerning for an aortic valve problem, which this fetus did have. We can see the aortic valve in our traditional views looks thickened, it's not moving well, and then when we look with color flow, again, we have that swirling with poststenotic dilatation. So for this family, the three-vessel view was very significant for their family because it did get them referred in for a fetal echo to make the diagnosis of aortic stenosis, which, as we know, can progress during pregnancy and become into a potentially single ventricle physiology. So this view, I think, for this family would argue that the three-vessel view should be part of our screening process. So our next case, so this is showing a sweep. So this is showing a sweep from the four-chamber into the three-vessel view. So as we come up, we see the pulmonary artery, we see the aorta, and we see the SVC. So at this point, the configuration looks okay to me, the sizes look okay to me, so I'm really not seeing anything in this view that's of any concern to me. So as we come up into the three-vessel trachea view, now here we can see this doesn't quite look right because now we have a left-sided ductus, our trachea here, but our aorta is coming over towards the right. So with this configuration, this looks more like the U-shaped configuration. So is this a right aortic arch? So if we stopped right here, this would be our diagnosis. But when you add the color Doppler and look very carefully, we can see, again, here's our flow coming around the ductus, here's the aorta, and we're seeing this tiny little jet of red and coming back and meeting with the descending aorta. So this is a case that I actually showed you earlier. This is double aortic arch. So again, when you detect a right aortic arch, you really need to look carefully for presence of a double aortic arch, and also see that you need to continue sweeping all the way up, not just into the 3-vessel view, but into the 3-vessel trachea in order to make an accurate diagnosis. And double aortic arch, as we know, is significant in that it's a tight vascular ring, and these babies could get into trouble with dysphagia or with trouble breathing. So I have one more case. So this one, so here's our normal. So we have normally 3 vessels. So when we look over here, we see 3 vessels, but the configuration doesn't look quite right. So we have 3 vessels, yes, but the configuration isn't what we expect to see with the pulmonary artery first, aorta, and SVC. Here we have a circular structure, what appears to be the pulmonary artery, and the ascending aorta, and then nothing over here. So this is what this one looks like. We're missing that SVC over on the right side. So in this case, this is a persistent left SVC with an absent right SVC. So again, you can have 3 vessels, but an abnormal configuration, and then this left SVC is still draining into the coronary sinus. So we should have a dilated coronary sinus as well. And as we track up higher, we can see that there is a right-sided brachiocephalic vein draining over towards the left in this case. So we do have a bridging vein in the absence of a normal right-sided SVC. And this is in our bicable view. So here we can see the IVC coming up into the right atrium, but we don't see the SVC. And again, as I mentioned, this vessel still drains into the coronary sinus, so we have a dilated coronary sinus. And lastly, I just wanted to introduce you to the aberrant right subclavian artery as well. So the normal branching pattern of the arch is the brachiocephalic artery branching into the right subclavian, right common carotid, followed by the left common carotid, and finally the left subclavian. With an aberrant right subclavian artery, we have the right common carotid branching on its own, left common carotid, left subclavian, followed by the aberrant right, which courses behind the trachea to go over to perfuse the right side. So in the 3-vessel view, we'll see this with low scale settings. You need to turn your scale down because this doesn't have quite as much flow in it, but we'll see it running behind the trachea. So if you see any vessel coursing behind the trachea, this should be considered an abnormal aberrant branch. And I just wanted to go back and make sure that to distinguish this from the azygos vein, which doesn't go behind the trachea. Instead, it courses up and drains into the SVC. So you can see the difference of the aberrant right with the azygos vein there. So the clinical significance of this is that it is the most common arch anomaly, about 0.5 to 1% of the population. It is associated with trisomy 21, although in isolation there are reports coming out that if it's the only marker, then it's certainly much less significant. But if you have other markers, then it does become more significant. So if you see this, then you should be looking very carefully for other markers of trisomy 21. So to conclude, the 3-vessel view is an excellent view to detect major heart disease involving the great vessels. I think it's very easy to look at, it's easy to learn how to interpret, and it's easy to get from first trimester all the way up into third trimester, as well as on your bigger patients. And it's also useful for early detection of congenital heart disease as well in our first trimester patients. And again, if you take the time and learn to become proficient with the color Doppler, that's going to even help you more so increase your detection of major heart disease. So thank you. I will take any questions now, if there's any questions.
Anybody have any questions, or were they all answered by the presentation?
Oh, well, that's perfect.
Well done. Well done. Well, oh, it looks like we might have one coming in. Let's give it just a second here. And I'm not, actually, looks like somebody is trying to send a question. Oh, here we go. Actually, what it is a comment. We have a comment that it was a great presentation, and I would certainly have to agree with that comment. And really appreciate Ms. Anton presenting this wonderful presentation to us. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. So long, everyone.